I'm very excited to be here today and have the opportunity to present to you about some of the work that I've been doing looking at healthcare utilization and associated outcomes among people who use drugs. Just as a disclosure, I have no conflicts of interest to declare today. As you all probably know, UNAIDS recently set an ambitious goal to scale up HIV treatment globally, where by 2020, it proposed that 90% of individuals will be diagnosed or will know their HIV status, and 90% of those individuals will be on HIV treatment, and 90% of those will be virally suppressed. So with this ambitious target set, one of the important questions that we need to ask, especially in terms of the research that I'm involved in, is what progress has been made specifically among people who use illicit drugs. In Vancouver, we've seen considerable progress in addressing the HIV epidemic among this population. This is a figure that was taken from the Drug Situation in Vancouver report, where it shows a huge decline in HIV incidence among people who inject drugs over time. We've also seen, similarly, a huge decline in hepatitis C incidence over time as well. And there have also been very positive HIV treatment outcomes among people who use illicit drugs. This is a study that's under review by my colleague M.J. Malloy that looks at plasma viral load over time. And you can see in the black bar, or the black lines really represent the median plasma viral loads, and you can see it declining over time. So with all this progress that's been made thus far, I only showed you a snapshot of it, but really we've seen progress, a huge decline in HIV and hepatitis C incidence, as well as a decline in plasma viral loads. One of the questions that we need to ask ourselves is, are there any challenges that remain? And of course there are. But specifically, what areas need to be addressed in order to reach our 90-90-90 target? So there's a considerable amount of research that's now really focused on the intersection between illicit drug use, infectious disease, and the delivery of health and harm reduction services. And this is where most of my research lies. Specifically, what we want to know is what barriers are there in accessing and utilizing healthcare services along the cascade of care that may have an impact on our 90-90-90 target. So this leads me to share with you 3 substantive research areas of interest that I've been heavily involved in over the past few years. First, I'll share with you some of my most recent work looking at hospital services and care among people who use illicit drugs. And then I'll talk about some of my work around harm reduction programs for crack cocaine use. And lastly, I'll share with you some international work that I've done looking at HIV testing services and peer-based initiatives among people who inject drugs in Bangkok. So all of the work that I'm about to share with you is really work that's done with the Urban Health Research Initiative, which, as you all know, is one of the programs of the BC Centre for Excellence in HIV/AIDS. The Urban Health Research Initiative really has 2 main components. There's a research component and an education and training component. I won't talk much about the education and training component, but within the research component, there are really 3 prospective cohort studies of people who use illicit drugs and street-involved youth that make up the backbone of the research portion of our work. And alongside that, there's various other programs that span across these 3 cohorts, including our ethno-epispatial program. We have work ongoing around clinical trials and structural intervention studies, community-based research, and policy and knowledge translation related work as well. And in addition to that, we have an international project in Thailand that's community-based research project of people who inject drugs, which I will describe later on in this presentation. So just very briefly, the Vancouver Injection Drug User Study, or VIDUS in short, and the AIDS Care Cohort to evaluate exposure to survival services, or ACCESS in short, are two open prospective cohorts of HIV-negative people who inject drugs, which are followed in VIDUS, and HIV-positive people who use illicit drugs, who are followed in ACCESS. And these studies are followed in parallel and have been ongoing since 1996, where we collect information on participants at baseline and then every 6 months afterwards through an interview or administered questionnaire. And we also collect blood samples for serologic testing. So now I'll just jump into my most recent work looking at hospital services and care. As you all probably know, people who use drugs are very vulnerable to an array of health-related harms that lead to frequent hospitalizations. While AIDS and overdose deaths continue to be the most common causes of mortality among this population, which is actually shown in this figure, which was a study by Degenhardt and colleagues, soft tissue infections are currently one of the most common causes of hospitalization among this population. There's a growing body of research that has identified hospitals as a risk environment for people who use illicit drugs. And what I mean by that is that while hospitals provide much needed and essential care for these individuals, they also may confer risks for various negative health outcomes. So for example, people with substance use disorders are more likely to leave hospital against medical advice. And we know from previous studies that leaving hospital AMA is associated with an increased risk of readmission for a worsened health outcome, as well as mortality. There's also some qualitative research that has looked at experiences in hospital care among this population. And this is a study that was conducted by my colleague Ryan McNeil, where it showed that, in particular, this participant said how having used illicit drugs and having had used illicit drugs in hospital, it may lead to various negative health outcomes like overdose. So this one participant said, "I think they pretty much have zero tolerance in the hospital. I was worried about getting kicked out and then not getting the proper health care that I needed to get better. I turned the tap so if they came in my room to check to see if I was okay, they'd hear the water running so they'd figure, oh, she's just in the bathroom." So a lot of the work that has currently been done around hospital care, discharge, AMA among people who use illicit drugs has really only relied on data from administrative hospital records. And one of the limitations of that is that we're unable to capture the dynamic behaviors, patterns, contextual factors that are associated with people who use illicit drugs. So what we were able to do was link our cohort data, which is data, as I mentioned, that captures various sociodemographic, behavioral, contextual factors, with St. Paul's Hospital administrative database that has information on admissions, discharges, and diagnoses. And one of the studies that we conducted was looking at various individual and contextual factors associated with leaving hospital against medical advice. We found that a large proportion, 43% of patients in the sample had left hospital against medical advice. And after having modeled these variables associated with leaving AMA, we found age, or younger age, which is consistent with previous literature, high-frequency heroin injection, and exposure to the criminal justice system were positively associated with leaving hospital against medical advice, whereas people who were stably employed were less likely to have experienced the outcome. There's also a growing number of studies that have really pointed to the possibility of people being inadequately managed pain care among people who inject drugs. So one of the studies that we wanted to look at was the relationship between being denied pain medication by a healthcare provider and in-hospital illicit drug use among this population. We found that half of the participants in the sample had reported having had been denied pain medication, and 43% of those reported having used illicit drugs in hospital. In a multivariable model, even after controlling for various confounders, we found that there still was a positive relationship between being denied pain medication and using illicit drugs in hospital, which may suggest, among other things, that maybe these people are using as a way to maintain their drug use or as a way to deal with the pain that they're experiencing. So the past few studies that I showed you really adds to the literature around the fact that hospitals indeed may be acting as a risk environment for people who use illicit drugs. And so we know that in the community, harm reduction programs have really been successful in minimizing the harms associated with illicit drug use. However, harm reduction programs that are available in the community are currently not available in hospital settings, probably because most hospitals operate under an abstinence-only based policy. So one of the questions that I was interested in asking was, is there a role for harm reduction in hospital settings? Just briefly, I'm sure you're all aware, Insight is one of the successful harm reduction programs in the downtown Eastside neighborhood, North America's first sanctioned supervised injection facility that has been shown to not only reduce public disorder, but also reduce risk of disease transmission as well as overdose. You also may know of the Dr. Peter Center, which actually operates just a block away from here on Comox and Thurlow. That is an HIV/AIDS integrated health program that provides support to people who face poverty, homelessness, mental health and addictions issues, and other comorbidities in addition to HIV/AIDS. The Dr. Peter Center has 3 core programs. So they have a day health program, a 24-hour specialized nursing care residence, and enhanced supported housing program. A unique aspect of the Dr. Peter Center is that it really has a harm reduction based model of care. And within the Dr. Peter Center, there is actually a harm reduction room where people are allowed to use drugs under the supervision of nurses and acquire various harm reduction supplies. So with that being said, one of the questions that we were interested in is looking at whether being a Dr. Peter Center client had an impact on leaving hospital against medical advice. And we found that indeed, even after adjusting for various social, behavioral, clinical confounders, there was a negative relationship between being a Dr. Peter Center client and leaving hospital against medical advice. What some of you may be interested to know is that the Dr. Peter Center actually was once located within St. Paul's Hospital. So it wasn't necessarily a stretch to want to ask whether people would be willing to use a supervised injection facility if it was available in the hospital. So we asked this question, and we found that 70% of people who used drugs were willing to access an in-hospital supervised injection facility. And that after running a multivariable model, people who are most willing to access such a facility were people who were high-frequency drug users, as well as those who had used illicit drugs in hospital, which, as I mentioned previously, may lead to various adverse health outcomes. So just to quickly summarize that work that I've done around hospital services and care, what we found was that various individual and contextual factors such as high-frequency drug use, as well as exposure to the criminal justice system, play a role in shaping retention in hospital care. And we also found that integrated harm reduction-based interventions, such as a supervised injection facility, may mitigate the risks associated with hospital-related outcomes. So now I'm just going to switch my focus a little bit and talk about some of the work that I've been doing around harm reduction programs for crack cocaine use. As you all may know, drug use patterns in Vancouver have been changing over time. And as you can see here in the red bars, there's been an increasing proportion of individuals who are reporting daily crack cocaine smoking, and less individuals reporting heroin injection or cocaine injection. So we also know that crack cocaine smoking is associated with a wide array of negative health outcomes, including cuts and sores in the mouth, as well as infectious disease transmission. This is a study that was conducted by my colleague, Cohort that found a positive relationship between daily crack cocaine smoking and HIV infection. So with the crack cocaine use epidemic being a growing public health challenge in this area, various organizations have tried to implement various harm reduction programs, including a crack pipe distribution program. So this is just a really rough and quick sketch of the scale-up of crack pipe distribution in Vancouver, where in 2009, really we were distributing crack pipes on a smaller scale with individual organizations distributing these pipes. And then in 2011, Vancouver Coastal Health took on a pilot project that were distributing crack kits at no cost in the area. And you can see in the photo on the left, this consists of a pipe, a mouthpiece, screens, alcohol swabs. And then most recently in 2013, and there's been a lot of media around this, where Portland Hotel Society recently implemented 2 crack pipe vending machines in the downtown Eastside neighborhood, where they're dispensing crack pipes for 25 cents a pipe. So before the scale-up of crack pipe distribution, I was really interested in looking at factors associated with difficulty accessing crack pipes in Vancouver. So what we found was that 33%, a third, had reported difficulty accessing crack pipes, and that the primary reason for not being able to access pipes was that sources were closed. We also conducted a multivariable model and found that various factors were positively associated with difficulty accessing crack pipes, including crack pipe sharing, which we know may be a mode of transmission. We also found sex work, and people who noticed police presence were more likely to have difficulty accessing pipes. And we also found that people who were had difficulty accessing services were also more likely to report difficulty accessing crack pipes. So this is a study that was conducted more recently where we wanted to evaluate the scale-up of crack pipe distribution and its impact on crack cocaine use. So this is a very descriptive figure, but basically you can see in the yellow line is the number is crack pipe distribution over time, and it's the number of pipes that were distributed through VCH. And you can also see in the blue bars that there has been a decline in crack cocaine use over time, as well as a decline in crack pipe sharing over time. Now, because most of this data, or most of what I showed you in the previous slide was very descriptive in nature. We wanted to model crack cocaine smoking cessation over time. And this is, as you can see, the model. We found a positive relationship between year, so every year increase, and crack cocaine smoking cessation during this scale up of crack pipe distribution, which to us may suggest that crack pipe distribution programs really don't undermine drug treatment efforts or perpetuate drug use. So we know that harm reduction programs work for people who smoke crack cocaine, but we also really wanted to address the crack cocaine epidemic from a treatment angle. As you all probably know, while there has been a lot of research done looking at the benefits of methadone and other opioid substitution programs on reducing opioid dependence, there really isn't an established pharmacotherapeutic option for crack or cocaine use. This is a systematic review that was conducted looking at psychostimulant drugs for cocaine dependence. And while the review overall concluded that there wasn't, this class of drug really wasn't efficacious in reducing cocaine dependence, they did find some potential in a specific drug class, which was the amphetamine salts. This is a study or a review that was more recently conducted last year by Kim and Lawrence, and this study looked at all drugs that were currently in phase 2 clinical trials for cocaine addiction and found that amphetamine salts and topiramate were two of the drugs that had the most potential in reducing cocaine dependence. This is a figure that they constructed looking at all of the drugs currently on clinical trials, where the x-axis represents biological half-life and the y-axis represents bioavailability. And their theory is that drugs that have high bioavailability and long biological half-life would probably have the most promise in reducing cocaine addiction. This study also included a study that was conducted by Mariani and colleagues at Columbia that looked at the combination of amphetamine salts and topiramate on reducing cocaine dependence, and found that this combo drug versus placebo was indeed effective in reducing cocaine dependence as well. So having reviewed the literature, what I was interested in doing is to conduct a RCT that tried to look at the two drugs and its impact on reducing cocaine dependence. So the main research question was, are individuals treated with the combination of topiramate and extended release Adderall, which is an amphetamine salt for those who don't know, more effective in reducing cocaine use compared to the single medications, provided that the single medications are more effective than placebo? So essentially, this study is really just in its infancy, but I designed a double-blind 2x2 factorial design placebo-controlled RCT that looked at these two drugs in combination and individually versus placebo on its impact on the proportion of cocaine-positive urine screens. And this is proposed to be a 17-week trial. However, during the process of developing this trial, there were a couple more studies that came out suggesting that maybe topiramate may not, in fact, be effective in reducing cocaine dependence. And these two studies are not included in the reviews that I mentioned previously because they came out after the reviews. And so the study is kind of on hold now while we wait for the results of actually the Mariani, the Columbia group, and the UPenn group are conducting a multi-site trial looking at the combo therapy, so Adderall plus topiramate, versus placebo on reducing cocaine dependence. And the results of this study are actually to come out sometime next year. So we're waiting for the results of that trial to see, based on the evidence, whether or not we should proceed with this particular trial. So just to summarize the work around crack pipe distribution and harm reduction programs for crack cocaine use, we found that crack pipe distribution programs are effective and do not perpetuate drug use. We also propose that topiramate and extended-release Adderall may be potential novel treatments for reducing cocaine dependence. So now we are going to fly halfway across the world to my hometown in Thailand, looking at HIV testing services and peer-based initiatives for people who inject drugs in Bangkok. So just by way of background, for those who don't know, Thailand has really been very backwards towards its drug policy. In 2003, our then Prime Minister Thaksin Shinawatra launched a war on drugs campaign that resulted in mass incarceration and almost 3,000 killings of suspected drug users. And almost a decade later, we can see that not much has changed, probably because then the Prime Minister was actually Thaksin's sister, who is now on trial for corruption, but that's a different story. And she proposed a drug strategy in 2011 where they wanted to target 400,000 drug users into compulsory drug detention, which we all know is a very costly and ineffective way of approaching drug dependence. So these types of policies have really led to an HIV epidemic that is specific to people who inject drugs. This is data that was taken from the Ministry of Public Health in Thailand, where, as you can see, over time, there have been a considerable decline in HIV prevalence among various other risk groups, except people who inject drugs. And here you can see there has been a persistent and consistent high prevalence of HIV among this population. So this really led to, because we wanted to examine and explore the experiences of people who inject drugs through their experiences with law enforcement and healthcare service utilization, we created the Mitsampan Community Research Project, which is a serial cross-sectional mixed method study of people who inject drugs in Bangkok. The data, we collected data in 3 waves over 4 years using an interviewer-administered questionnaire. And in 2011, we added our qualitative component to our research. The photo on the left is the Mitsampan Harm Reduction Center, which is a peer-run drop-in center and is where most of our research was carried out. And then the photo on the right is a photo of some of the researchers and participants in the study. So what I was interested in looking at was access and barriers to HIV testing services among people who inject drugs in Thailand. And this study that was conducted and published in AIDS and Behavior looked at HIV test avoidance among this population. We can see that there's 13% of people in the study reported actively avoiding HIV testing. And those who reported actively avoiding HIV testing were people who had high risk of HIV transmission, such as individuals who were high-intensity injectors, as well as those who had reported syringe sharing We also found that people who noticed police presence and those who had been refused healthcare services by a provider were more likely to also actively avoid HIV testing. So this really suggests the need for novel testing methods to be able to reach this population that may not be reached through more conventional testing methods. So as you know, peer-based initiatives have been very positive in terms of reaching hard-to-reach populations. And so one of the questions that we're interested in asking, especially since we were actually run out of a peer-run drop-in center, was whether people were willing to get HIV testing at a peer-run drop-in center if it was available, because currently in Thailand it's not widely available at peer-run drop-in centers, and mostly people are going to hospitals and clinics to get tested. So we found that 3/4 of participants in the sample had been tested for HIV in the previous 6 months, which is a high proportion of individuals and is probably likely attributable to the fact that around that time the tenofovir trial in Bangkok was ongoing, and participants in that trial were tested for HIV as well. So the high proportion likely reflects that. However, we found that those who were not tested, the large proportion of those who weren't tested believed that they were HIV negative and also engaged in syringe sharing. We also found a large proportion, 3/4 of participants in our sample, reported willingness to receive HIV testing if it was offered at a peer-run drop-in center, which suggests that these types of harm reduction centers, like the Mitsampan Harm Reduction Center, may have some important value in trying to reach certain populations that aren't normally tested. So because of some of the positive results that I found in the previous study, I wanted to take it one step further and really look at whether, in fact, people would not only be willing to get tested at a drop-in center, but also be willing to get tested if it was delivered by a trained former or current drug user. And what we found was that overall, over 1/3 of the participants reported willingness to access peer-delivered testing and counseling. You can see here that the least number of people were willing to receive post-test counseling, and while doing qualitative interviews, we found that this was probably largely because of confidentiality issues, so people were afraid to share the results of their test with their peers. We also ran multivariable models for each of the 3 stages of testing and counseling, and found quite similar results across the board. So people who were high-intensity drug users and people who had barriers to accessing healthcare services, as well as those who had ever reported being incarcerated, were more likely to be more willing to access peer-delivered HIV testing and counseling. And these were positive results given the fact that these individuals are probably not captured in more conventional testing services like in hospitals or clinicians. So we also conducted qualitative research, as I mentioned, in 2011, and one of the things that we really looked at was people's experiences and willingness to get tested by a peer. So basically, what I showed you in the previous slide was more quantitative work, whereas this really validated our research findings. So one of the participants said, "Drug users stick together. Decent people won't want to hang out with us. Nobody wants to hang out with us. Most of the time, the positive drug users hang out together, checking on each other's health and blood to make sure we're okay. Another individual said, actually, peer-delivered testing makes me feel more comfortable than going to see the doctor. They were users before, they speak my language. So just to summarize some of the work that I've done around HIV testing in Thailand, we found that there was a high prevalence of HIV testing, possibly largely because of other studies that were ongoing around that time. But we also found high-risk behaviors among those who were not routinely tested and those who actively avoid testing. We also found that peer-based testing initiatives may be effective for improving access to HIV testing in Thailand. So just to conclude, all the research that I've shown you thus far is that really there has been substantial progress made in addressing the HIV epidemic among people who use illicit drugs. However, there are some challenges that remain both nationally and internationally, including areas that aren't necessarily directly related to HIV, but really indirectly will affect our 90-90-90 target. So things like retaining people who use illicit drugs in hospital care, appropriate distribution of harm reduction services, and engaging people who use drugs in HIV testing services. Our studies do, however, point to opportunities to improve health service utilization among this population, including our study that showed integrated harm reduction programs in hospitals may reduce hospital-related outcomes among this population, expansion of harm reduction efforts for people who use crack cocaine, and peer-based initiatives for HIV testing. Lastly, I'd just like to thank the study participants for sharing their experiences, the Urban Health Research Initiative, and the BC Center for Excellence in HIV staff, as well as our funders. Thank you.